I have a few cases actually. I'm back this week.
Great.
So I've been gone due to illness and been gone on travel and things like that. So
It's do I hear Art and Nick laughing in the background?
Yes,
they were laughing because they wanted me to be more aggressive. So I don't know what that means, but anyway. So can you see my screen?
Yes.
Okay. So this is one that that Art Stillman, courtesy of Art Stillman. This is a young patient, I believe about 28 years old, who had by echo a gradient across the aortic valve on echo, and you can see here as you scroll through the axial images that the aortic valve is abnormal. It's 3 leaflet, but you can see that there's this asymmetric thickening of the valve leaflets here toward the right and non-coronaries, and you can see that as you scroll down, something abnormal going on right here, and we're going to reformat that. Let me just do that here. And here you can see, let me blow this one up. You can see that there is a subaortic membrane here, and that's causing narrowing here along the LVOT. And you can imagine that the jet that's created there might be the explanation, probably is the explanation for why there's this asymmetric valve damage. You can see that this leaflet is thickened. It's presumably right in the direction of the jet, and of course turbulent flow was noted on the echo, and it's probably channeling the flow right through here along this this valve and causing that asymmetric valve thickening and valve damage. There's also some asymmetric hypertrophy of the LV, but presumably most of the outflow obstruction is due to this subaortic membrane, then causing some asymmetric thickening and damage to the aortic valve. I just thought that was a really kind of cool demonstration, of subaortic membrane presumably causing this type of asymmetric damage. Have you all seen that before? Or?
No. What is the pathology of the subaortic membrane, that LVOT subannular membrane? Is it a thing? Is it a entity?
Congenital entity, but I don't know the full embryology, but congenital and in etiology, and it's a known entity, but I've never seen a case like this where you could clearly see this asymmetric valve damage. So, but anyway, thought that was really cool.
That is interesting.
What do you think the treatment? What's the treatment for that? Do they go in and resect it?
Well, yeah, they're gonna presumably they're gonna go in and resect this. You can see that there's a little bit of septal, there's some concentric, a little bit of asymmetric, LVH as well, but presumably you can imagine how most of the obstruction here is going to be due to this membrane. So presumably resect the membrane and see what the flow is like then. But yeah. All right. So this is just a really quick one. Let me pull up the screen here. All right. So this is a young patient with this chest X-ray, and you can immediately see that, of course, there is really, really dense sclerosis of all of the bones, and actually our residents are very good, but when this popped up and I asked one of the residents, not the ones with me in the room right now, but it's another resident said, "Oh, could that just be artifact?" And I was like, "Well, this is not." It'd be a lot of artifact, but just really, really dense bones, and this is a case, and you can see that there's this bent, sort of dysmorphic appearance of the humerus here as well, and thickening, expansion of portions of the humor right here. So this is a case of osteopetrosis, just a really good case that just came in, of young patient with osteopetrosis. So just really, really dense bones, some dysmorphic appearance of the proximal humerus, and I just thought that was just a striking example.
Hey, Brent, is that a catheter or a drain over the right upper quadrant?
Yeah, this is. I think they had had a renal stone and had some lithotripsy, I think, and had a drain related to that. So
are they at increased risk of stone formation? I'm guessing. I don't remember the pathogenesis of osteopetrosis.
I believe they are at higher risk of stone formation, although I don't know the mechanism. Does anybody know the mechanism? But this is for, they had a concurrent, they were in the hospital for lithotripsy.
And how old are they? Because it looks like a pediatric film. Is that just, or radiograph, is that just their?
Well, they're an adolescent, so
Yeah.
they're not a really young patient, but in the teens, I believe. I can't remember the exact age, but sorry, 23.
Okay.
So
Wow.
I guess she does have breast tissue. She should be fully grown.
But it does, it does have this kind of narrow appearance, sort of, rested appearance of the thorax, So anyway, that was just a quick one. This one is one I really like. So I'm going to show 1 second. Okay, so let me. Okay, so this just came through yesterday, I think, and this is a patient history withheld who has this, architectural distortion, some of it's varicoid, some of it's cylindrical bronchiectasis, has some traction, looks like almost a tethered appearance. The fissures are both very anterior predominant bronchiectasis and fibrosis pattern. And you can see that, next question is, are there any tree and bud nodules? There are no tree and bud nodules. Let's go back up to the upper lungs. You can see that this is not really a bulla, but more of kind of a loculated pneumothorax. And you can see that this up here is part of a loculated, resolving loculated tethered anterior pneumothorax. You can kind of see that better on the sagittals here. Let me show you sort of in this area. And so let me show you, the history was withheld, but she had come in with about 2 weeks of, let me flip to the prior CT. This CT was 3 months prior to that CT. Let me show the screen here. And she looked like this. Switch to line windows. And the history here is, this is a patient in the 30s who had a few weeks of kind of cough and then went downhill. About a week of cough, went downhill, and tested positive for influenza A. And you can see here this really, really nice bronchial dilatation pattern within the lower lobes with consolidation, dependent consolidation, glass and everything. You can see some bronchial dilatation anteriorly too. And of course, this suggests an ARDS pattern and diffuse alveolar damage in the setting of her influenza pneumonia. And flipping back to the other CT, this is the classic, let me bring up the screen again, classic anterior predominant fibrosis that you can get after ARDS. And I have to say that this is probably the most, the most textbook case that I've seen so far of this anterior predominant fibrosis, presumably due to the barotrauma that the dependent consolidation protects against in the setting of prolonged intubation. But I just thought that was a beautiful case of anterior predominant bronchiectasis and fibrosis in the setting of ARDS due to influenza pneumonia. So
I think the etiology here is the pneumonia. Rather than invoke ARDS, that was probably a component of the pneumonia. I think this is post-infectious scarring. I think that's a better description. It's really peribronchial. It's upper lung where the virus tends to predominate. And you don't have it in a generalized sort of way that would go with the usual ARDS where you get, lung damage all over the place. The rest of the lung looks quite good here. So I guess I would skip the attribution of ARDS here and just go with post-infectious scarring.
David and Brent, two things. One aside is she's got a nice dual congenital anomaly. She's got a tracheobronchus and a left SVC.
Yep. Right.
I'm seeing central lobular ground glass nodules all throughout the lungs.
And she still has central lobular ground glass within her lungs. So
do you think that's
whether that
organization around the airways or the residual bronchiolitis?
it could be. I just gave a differential, residual bronchiolitis.
Okay.
She did not have recurrent sort of, pneumonia-like symptoms.
Okay.
She does have a ton of bronchiolitis.
It's interesting. It's just
I think the thing that for me that favors ARDS is not only clinically did she have ARDS, but also look on the prior CT. I mean, in fact, this is in my mind it's kind of classic post ARDS anterior fibrosis. But look at the bronchial dilatation that you had down here. We see many cases in which this, and the reason I'm not calling it bronchiectasis is that it returns to normal.
Hey, I'm not seeing the old CT.
Oh, sorry. Let me look at. Yeah, so old CT. So you have a ton of bronchial dilatation, and you have consolidation, and certainly she did have pneumonia. But when in my experience, and I guess a lot of literature suggests this too, that when you have so much varicoid bronchial dilatation in the setting of this pattern, it suggests an ARDS, and this went back to normal, almost completely, which we've seen a lot in ARDS. So I guess that's why I was invoking, and clinically she was, had ARDS clinically. So I don't know. That's interesting. I mean, but you're saying that you would not invoke ARDS in this setting, or?
I would say post-infectious. I think the infection explains the eventual pattern of scarring, and I don't think you need to invoke ARDS, which implies to me that there's a more generalized response throughout the lung, not just in the areas of infection. Of course, infection leads to alveolar damage, but when the infection is cleared up, I mean, most of that lung really doesn't have this scarring pattern. So
right, but that follows. Yeah, I mean that kind of follows the classic post-ARDS though, feeling that you have residual anterior scarring but not posterior scarring. You know what I'm saying? I mean, I guess I'm, maybe it is a little pneumonia, but that's kind of the classic thinking on post-ARDS fibrosis, right? That it's more anterior predominant.
Well, yours is more localized though than the post-ARDS scarring that I've seen, which is more generalized, and goes where the ARDS goes, not just where the infection was.
Okay. All right. Well, interesting. So, all right, and I think let's see. Oh, just one last one, and then I'll give up the table here. So let me show you the. Okay, so here's the chest X-ray, and so it's very interesting because look at the right atrial pacemaker lead. So it's projecting outside the confines of the right atrium. And so actually one of our, breast fellows who's reading radiographs on a weekend actually pointed this out, caught this and said, wow, what's going on here? We suspect that pacer lead is not where it should be. And you can see that here's the CT, and the pacer lead is perforating outside the right atrium and going into the lung there. So this was a case of a chronic pacemaker perforation through the right atrium. And shockingly, I thought, they actually removed this. They extracted both of these leads, and we looked at the op note, and the op note said, well, with some gentle traction, the leads were extracted. So it's kind of shocking that with some gentle traction,
you have to stop with the pun. It's just really bad.
What's that?
The pun needs to stop. It's really bad. You did it twice.
Shocking.
Oh, yeah.
Was that verdant or inadvertent?
That was inadvertent, of course. So I apologize for the unintended pun. But yeah, I just thought that was a very nice example, and yes, so good pickup on behalf of one of the breast imaging fellows who was reading some of our films. But anyway, so thank you very much. Those are all the cases I have.
All right, thanks, Brett. Those were great. All right, who's next?
I've got a couple.
All right.
So I wanted to show you this this young man here who came in with profound dyspnea and desaturation, and he has an interesting history. So let me start with this radiograph here on your right here, which is a few years ago when his lungs were clear. And then on the current admission, this is what his lungs look like. There's a fine nodular pattern, seems to be mid-lung and basal predominant. And this is what his CT scan looks like.
Is he young guy?
I'm sorry?
He's young, right? In his 20s? 30s?
Yes, 20s. 20s are actually 31.
Okay.
That counts as young. Okay, so he's got this floral bronchiolitis pattern here. We didn't do expiration views to see how much air trapping is accompanying this, but it seems to be worse in the bases, mid-lungs and bases. And there's some bronchial wall thickening up here, so it seems to be large airways and small airways that are involved in this process. And then he has quite a bit of lymphadenopathy here in the mediastinum and hyla. So a bad bronchiolitis pattern. Now he has this provocative history of a few weeks before he was helping a relative clear out a foundation for some construction, and this foundation was I think he was working in a crawl space, and he was exposed to a lot of dust and a lot of mice and mice feces. So everybody was concerned about hantavirus, which is in Washington State. So hantavirus was a consideration, but this doesn't look anything like the cases of hantavirus that have been reported, which look more like lung edema. There's often accompanying perfusion and so forth. Lung edema that may go on to ARDS. So this doesn't really look like that. The other thing is that he is a psychiatric patient who is compliant with his medications, but he also uses a lot of marijuana. He's an inveterate marijuana user, and so the question of could this be marijuana, aspergillus dissemination to the lung or some other organism that can contaminate marijuana? But the form of marijuana he likes to use is called dabs, and dabs means that you extract marijuana and concentrate it using some solvent such as butane. And then you get this resiny kind of glop, and then you heat that to high temperature on something called a nail, which is a piece of metal that you heat with a blowtorch. And then you basically vaporize this and inhale it, and it's very concentrated marijuana. It's like 80 times the concentration. So when I saw this pattern and I heard about marijuana, I asked, is this one of Travis's patients who's using synthetic marijuana? Because I pulled Travis's article on this, and this is almost an identical pattern, basal predominant tree and bud bronchiolitis pattern. So perhaps this is due to this particular preparation of marijuana that he's using called dabs. And let me pull up an article. I think I have an article on this to show you. So
David, you know an awful lot about these preparations.
Well, when I brought up the question of whether he was using synthetic marijuana, and his doc, who looks kind of like a young hippie, went up and talked to him, and the guy gave him a complete description of this dabs operation. But I figured that you guys would be the experts, so that's why I'm showing you. So there are lots of ramifications of this butane hash oil. So this dab stuff is sometimes called hash oil, meaning you extract the marijuana as solvent. And what it tends to do is blow up on people. So there are a lot of people who come into the hospital with burns or inhalational injuries from this. So here's the sort of stuff that you extract. Then you heat this on with a hot surface and stuff like that, and inhale the vapors. This article is describing people who came to the emergency room with, in this case, pneumomediastinum and burns on their bodies and stuff like that. This is the sort of apparatus you can use where you heat it below. You concentrate the vapors up here. Here's the torch that's doing the heating, and then you vaporize this stuff, and this is called a ring or something like that. It's kind of a kind of bong, and you inhale this stuff. So I'm wondering whether this is dab lung here, whether this is a variant of the concentrated marijuana effects that Travis described in his article, the synthetic marijuanas. It wasn't clear to me from the article that Travis co-authored whether it's the marijuana itself that might lead to a bronchiolitis or contaminants in the in the inhaled material, burn products and solvents and things like that.
Yeah.
But it struck me that this is a similar situation of very concentrated marijuana or synthetic marijuana, which is the equivalent of very concentrated marijuana, or something else that's inhalational. And the hantavirus is being pursued, but that's a long shot. So far, there's been no bacteriology or virology that has explained his bronchiolitis. So I'm not sure that this is related to his drug abuse, which he, in the state, it's not abuse anymore. You're encouraged to do it, I think. And he, that's been ongoing, or whether this is an infection that we just haven't diagnosed yet. But I wanted to bring this to your attention, see if you guys have any similar cases and people who might be doing this dabbing. So dabbing is this preparation of concentrated oil or resin, and then heating it and inhaling it. So dabbing.
Yeah, I think it's probably the contaminants in there. We were unsure in our cases, but they were all types of synthetic marijuana.
Right.
David,
Yeah.
I've seen one case where what we're seeing is bronchiolocentric organizing pneumonia from whatever body compound they've inhaled.
Right. We had a case like this about 6 years ago, and there was a biopsy in that case, and it had a bronchiolitis that looked just like this, and they diagnosed AFOP, so acute fibrinous organizing pneumonia. So it's an organizing pneumonia with a necrotic component to it, and it was all in the airways. And so this looks a lot like that case. That was a 19-year-old, and people didn't quiz him about his drug abuse, and he had a lot of complications from that. He did not do well. So yes, I like the idea of an organizing pneumonia, an AFOP organizing pneumonia that is part of this bronchiolitis. So keep your eyes peeled, you guys in big cities like Salt Lake.
Yeah, we like that case. Yeah.
I think were all those canisters? Were all those butane canisters? Was that?
Well, they use butane is one of the ways of extracting the stuff. Butane is a solvent that will help you extract, and then you can evaporate it, and you can get the concentrated resin. So butane is one of the solvents that's used to extract the THC from the marijuana leaves.
Okay. Wow.
Okay, so this next case is a guy with hepatocellular carcinoma from HCV infection, and his radiograph shows a nodule here that looks like a metastasis sitting in the left lower lobe. And he got the CT scan, which shows the genesis of this nodule. So first of all, he's got cirrhosis and ascites, and he's got a mass of varices here in his mediastinum. And then if we follow these varices up here, we see that the varices actually flow into this lung lesion down here, and this lung lesion is an extension of varix into the lung. I think I have another series that's going to follow here. I think, yes. And here is that lesion shown better on a delayed phase. Here you can see the varices, which are now more opacified, leading into the lung here. And on a coronal view, you can see the connection that this venous abnormality here makes to inferior pulmonary vein. So here's our lesion that has left the variceal cluster, and then it connects here to an inferior pulmonary vein. So we've seen a few of varices that have connected directly to the left inferior pulmonary vein. And so you've seen a nice anastomosis. This one is a little more peripheral. It's not the main part of the vein that's where the connection is, but a little bit lower to a more peripheral branch, which ultimately leads to the inferior pulmonary vein higher up. So here's the connection back up. Yeah. So another case of varices that managed to get into the lung or the lung circulation.
Yeah, it's a nice example of that.
Is this pulmonary artery enlarged? I've seen that in a lot of these patients with portal venous hypertension, and I presume it's from increased either just the liver normally acts as a giant resistor and isn't. This doesn't look that big.
Pulmonary arteries aren't that impressive here. So you're saying that the portal hypertension leads to pulmonary hypertension?
Yes.
Or
And some of it may be humoral, but you'll see they have big azygous veins but I think of the liver as sort of like a giant resistor for the systemic venous system. I'm wondering if he had that as well, or if maybe he's decompressing through these varices instead, and the left heart's dealing with it.
Okay. And my third case is this florid example of tumoral calcinosis, this dramatic calcification around both shoulders in a person with chronic renal failure and hemodialysis for a long time. And I think I have a CT on him that also shows all of these calcium collections here in the soft tissues around the shoulders, medial to the shoulders. And the other thing that he has is some very interesting DPO-like lung calcification way out at the periphery and the bases. Looks like confluent DPO, and here it's more speckled on the other side. So another component of calcification in tissues where it doesn't belong. And this really looks like pulmonary ossification. We don't have any biopsies of the lung to see that this is bone and not just calcium. But these uniform little spots in this particular subpleural basal location is very good for DPO as a component in this person to this widespread abnormal calcification. So tumoral calcinosis and presumably DPO. Okay.
All right.
Very good. Yeah.
Thank you. All righty. Who wants to go next?
I'll show a couple.
All right.
All right, I'm going to start with this case. I've got a couple of truly shocking cases that don't have anything to do with pacemakers, but Brent and Art and all the cardiac guys there will love this one. This is, unfortunately, it's a terrible exam. It's from an outside hospital. This is a middle-aged woman, no past medical history, who presented with chest pain and fairly, quickly, rapidly developing hypotension. Of course, they do a PE study, and you can see that she's got a large volume of pericardial fluid. And even though there's so much noise on this study, that you can see that it's high attenuation. It's 50, 60 Hounsfield units. So it certainly looks like hemopericardium. And so I think oftentimes we've shown, dissection, intramural hematoma involving the root as the cause of the hemopericardium. But in this case, check out what is happening right here. There's this big spherical thing, and it's right in the right atrioventricular groove. And even though it's such a crummy exam, I think you can hallucinate on one of these images that it looks like it's arising from the proximal right coronary artery right here. You can see her left coronary arteries, her left main, her LAD, they look normal caliber. And so, of course, she got transferred here and went straight to the OR, so we know what this is, but when I saw this, I didn't have the operative report. It looked like a big RCA aneurysm, which is what we thought was going on. And it turns out that's what it was, that this was a ruptured right coronary artery aneurysm. We have no idea why she had it. She doesn't really have a lot of atherosclerotic disease. And I haven't seen the final path yet because this was just recently. But this is the first of these that I've ever seen with an aneurysm presenting with rupture of a coronary artery like this. I don't know. Has anybody else seen this?
No.
No.
So, and I'm just getting a text from my fellow saying that she's scheduled for a coronary CTA today. Interesting. So,
I would tamponade very quickly and not survive.
Well, yeah, I mean, she clearly had tamponade, and you can see how compressed her RV is. But it's amazing that she did survive. Yeah, but it must have, not been. It's a small enough vessel that perhaps it tamponaded itself off once it got to a point that it just didn't bleed much anymore or slowed down.
That's true.
But yeah, so, but pretty dramatic case.
Mm-hmm.
Wow.
It's a great case.
That's odd.
And then here, speaking of tamponade, this is an exciting case. And this is an 80-something-year-old woman who underwent TAVR here on the date of this exam. So this is a few hours after her TAVR. She was doing great. went to the ICU, and then all of a sudden wasn't doing so great. Developed hypotension. And as you can see, this is an abdomen and pelvis CT. So I'm not sure exactly what went into the thought process, thinking that this must be mesenteric ischemia in somebody who had just had a procedure, but that's what they thought. You can see on the smart prep, and I show you this because it's kind of interesting, but you can see she's still got most of the contrast from her TAVR placement in her kidneys. So she's got some delayed excretion. And I show you that I always like looking at the timing boluses because I think it shows us a lot of physiology. And she's being injected through an upper extremity. And we see where most of the contrast is going, which is into the dependent portion of her liver. And you've got a contrast fluid level here, and it's pooling. I showed that case a few years ago. The patient that was in asystole on the scanner looked very similar to this with the degree of contrast. Now, she's not in asystole. But what you will see, fortunately we caught this, is that she has a large pericardial effusion. Now, I'm showing this. This is the non-con, which was done before the Smart Prep series. As you can see, the timing of the 2 minutes before. And what's fascinating is how high attenuation this is. So I don't know. The bottom line is this ends up being blood in the pericardial space. They didn't find a frank site of rupture from her TAVR, but it's undoubtedly related to the procedure. And I don't know if it's, if they injected contrast that extravasated into a pericardial space, or if it just leaked through wherever the injury was, if this sealed itself up or whatever. But anyway, I don't know. But they did this study, and so clearly the reason she was having ischemia type symptoms was just reduced output from this, and there was no pseudoaneurysm, no rupture of anything that they could find. So they went to the OR, evacuated 300 cc's of blood, and then she just went home today. So
how high was the attenuation in that originally?
I think that stuff's over. I think it's over 100 Hounsfield units. Let's see.
So it has to be contrast then.
Right.
Yep.
Yeah, it's 173.
Yeah, they injected contrast during the performance of the TAVR.
Yeah.
During the placement of it.
Yeah.
And something happened.
Right, but what's really interesting. Yeah, and I don't know. I remember we used to think that this was pathognomonic for contrast-induced nephropathy when you had retention of contrast after hours or days after another exam. I don't know. I mean, clearly it's indicative of reduced renal clearance. I guess the question nowadays is it due to the contrast, or is it just due to something else with reduced function? But yeah, so I don't know if it's just that she's got, even her atelectatic lung looks, high attenuation for a non-con, and clearly you can see that she's got contrast still in her chambers too. So yeah, she's just really, they must have given her a lot of contrast, and it's just clearing extremely slowly from the procedure. But it's a mystery. We've had one other case of hemopericardium after a TAVR. They went in, opened them up, didn't find the source. So I don't know. But I thought this was a pretty dramatic case too.
Wow.
Why is there angiography as part of the TAVR? What exactly are they doing with contrast during the procedure?
So they're trying to find. They're just looking at the aortic anatomy. They're looking at where the coronaries are. When they're trying to place the valve, they use a lot of contrast, repeated injections, just to make sure they have the valve seated in the correct place before they inflate it.
And that's from an arterial puncture then. It's retrograde in the aorta that they go back.
Yep.
Yeah. If they're doing this transfemoral, then it'll be a femoral catheter. This one was transfemoral. That's a good point, because you can certainly, they do these transapical in some cases where you actually go in through the apex of the left ventricle. That was not the case here, but that would be another reason to have hemopericardium.
Mm-hmm.
So I don't know. Art, Brent, Nick, any other thoughts?
No, we were just thinking it, definitely looks like contrast, so presumably somehow contrast got in there.
Yeah. And I want to show one more quickie. And this is for Howard. I just saw this morning, and I'm gonna, let's see, I'll go through briefly. So this is a guy with he's got leukemia of sorts. I don't remember what, but here he is last month on the 20th, and not too exciting. He's got small effusions. Then he comes back a couple weeks later, and you can see that there's now, he's got some septal thickening, which is predominantly smooth. The effusions are still there, but in addition, you see a couple little peculiar nodules here. It looks like little nodular septae, but some of them aren't clearly associated with the septae, like this one here, and there were a few higher up, but I'm sure Howard knows where I'm going with this, because this guy clearly has a little bit of volume on board. These are really peculiar. And then we just saw it today. So that it was kind of diffed that he had edema, and then wasn't sure, the person who read this wasn't sure what else was going on. But now today, they didn't treat him for infection, and his edema's gone, and these little nodular things are gone. So I think these are all just little lymphatic pearls or venous lakes or septal lakes. Yeah, septal lakes, or yeah, what's the term you're using these days? Because lymphatic pearls was the first one.
Yeah. Well, it was based on the original article that described the phenomenon. They called them lymphatic pearls, but we wondered whether the water is really in the lymphatics or just in the septum. So we decided perhaps we should call it septal lakes.
I like septal lakes better too, but
sounds like real estate deals, real estate development. You know,
oh yeah, there's
septal lakes.
Yeah. So
that corona is really nice because I think one can see that they correspond to interlobular septa.
Sure. I totally agree.
Yeah.
So, but I thought this was cute just because we had these 3 scans over the course of less than a month. And of course, with leukemia or lymphoma or whatever it was, the question was, could any of this been, recurrence or progression of disease? And, maybe, but not the fact that it has gotten better with just diuresis.
Yes.
So.
Yeah. Yes.
All right.
Okay.
Those are mine for today.
All right. Cool.
Okay. Okay, let me show you this interesting case. Just for context, I will tell you this person has tuberculosis, and I'll show you a radiograph from 2014 compared to, say, 15. And you can see that over time, that right lung is just kind of disappearing. And you can see the evolution of extensive bronchiectasis within that lung as the lung parenchyma is kind of disappearing. And there's also some pleural disease. So the context is severe tuberculosis with progressive scarring of lung, disappearance of lung parenchyma effectively or mostly, and leaving the patient with bronchiectasis that you can see there very nicely. So this is interesting from the point of view of this. So let me bring you up the CT and just get my bearings again. So we'll see a lot of the airway, the parenchymal and the pleural disease and the bronchial disease. But I'm going to put up alongside that one a later CT from, so this goes back to September of 14, and I will go to November of 15 and bring that down. I don't know why these things scroll automatically for me. Sync, it's really annoying. So you will see here that perhaps analogous to the situation in which one has pulmonary artery stump thrombosis in situ after pneumonectomy. And I think I've shown 1 or 2 cases of a stump thrombosis in the context of a lobectomy. I think it's likely that this is forming because there's really no blood flow really going into that lung. Well, there is some blood flow, but it's presumably sluggish. And maybe that's the mechanism by which this in situ thrombosis occurs in the right pulmonary artery. So it's quite large there. And I think it got a bit bigger. So let me go to June of this year. And let's look at the size of that. No, that's post-op. So I will tell you that, let's go to February. There you see it there. So I think the most likely the explanation is just in situ thrombosis and progression of it in the context of slow flow. So this person apparently has been sputum negative for TB, but she persists in having symptoms and signs of infection or episodes of a febrile illness and symptoms. And eventually a clinical decision was made to remove this lung. So that's what happened fairly recently. So they went in and took out that lung on the right side. And I'll just show you that. So she's currently in the house and she's had that surgery. And you can see they did this under cardiopulmonary bypass. They went in there, did the pneumonectomy. This is a very proximal stapling off of the right pulmonary artery, took out the right lung. I'm not quite sure of the clinical context in which the repeat CT was done, but there's air and fluid in the post-pneumonectomy space. But I think it's the first case of a stump, kind of analogous to a stump thrombosis I've seen in the case of this. Has anyone seen something quite like that?
So it might have been this guy.
Of in situ thrombosis in this kind of context?
Howard, it's interesting if you, on that scan there, if you go down, it looked like the pulmonary venous return was pretty robust on that side. Maybe I was, usually we see
it's still coming in.
Usually we see kind of that sluggish flow.
Yeah. Here's superior and inferior. There's still blood flow going through that lung right there. Yeah, it's true.
But you get some sort of like smoke there, but it's
going around.
But I think you're right, because what also could be happening is the lung normally filtering stuff. It has a nidus sort of to adhere to and not break it down. And so you've got all this, maybe you do have some sluggish flow and you just don't have good clearance.
I don't know.
It looks like it's adherent to that lung distally and just kind of growing up the pulmonary artery.
Yeah, it is, isn't it?
Huh.
So that's kind of curious, isn't it?
I wonder if on the explant pathology they can sort of get a sense of anything about that thrombus. It'd be worth looking at when they release the path.
Yeah, I'll see if they examine that at all in any detail. They may not have, given that it's just a lung that's come out. They may not examine that pathologically very much. But I thought that was kind of interesting. And this is interesting because I think it's another case of what I showed a couple of weeks ago, equally dramatic, of what definitely in the previous case was lung edema in the context of air embolism during the performance of a neurosurgical procedure. And this one is interesting because I think it's another one, which is things sometimes just happen that way. So this person came in and was transferred with an epidural hematoma. And this is, at this time, is the evening of the 10th. And I will show you that in terms of the timing of things, this is just after midnight. So between these two images, the patient went to the operating room, had that evacuation procedure, and here I'll put up some notes from that, as you can see what they did. But I did find a note in the chart after this exam, or a little bit later in the morning here, and you can see the timing. This was around, the note was dictated around 11 o'clock. So that the surgery was done just before that, and then this is just after midnight, right? I did find a note in which it was said that neurosurgery ascribes this to air embolism during the procedure. And certainly the florid lung edema is definitely consistent with that. So I couldn't find any other note about that, but I think it's very plausible. And someone apparently did decide, or neurosurgery did decide, that there was probably an episode of air embolism during this procedure. And this is pretty florid lung edema. So I think it's the second florid case I have now. I don't have TE evidence of this, but by history, it seems to be the case. And let me show you this one. Okay, this is just a nice example of an opportunistic Aspergillus infection in a patient with a history of cardiac transplantation. So let me bring up the more recent chest radiograph to show you the opacities that developed in this person. I'll show you a couple of images from the CT that goes along with that. In terms of time, this is 2 days between these two. So let me get to the big one that you can see there. It's quite large, it's nodular, there's an area of cavitation within, focal opacity consolidation adjacent to it. What is nice over here in terms of teaching is these are beautiful examples of centrilobular opacities. So we have lobular airways full of stuff, and in some locations we probably have material coming out of the lumens of the bronchi or bronchioles into the pulmonary lobule, almost acinar nodules. So this, in this case, turns out to be Aspergillus niger, N-I-G-E-R, and I couldn't remember about that, but I think after fumigatus and flavus, the third one that occurs is niger, and this one on culture turned out to be Aspergillus niger. And he was treated for that and did quite nicely, so that got better. This is the healing with antimicrobial therapy. So Aspergillus niger.
I'm sorry, Howard, what did you say was the underlying context? Was it heart transplant?
Yes, heart transplantation. Okay. Yeah. Yeah. One of the clues for those of you that, I don't know how often you see this, but one clue, if you look at a post-op image and you have no context whatsoever, but you see sternal wires, and then you see fragments of pacemaker lead, that's the hint that the transplantation was the etiology. So sometimes when they have a CRTD device prior to transplantation, and at the time of cardiac transplantation, they remove that and or the LVAD, but sometimes they have difficulty removing these at the time of transplantation. So that's often, to me, a hint. I've seen quite a few cases. If you have remnants of pacemaker leads with the sternotomy wires, oh, this person has a cardio-MEMS too. That's a clue that cardiac transplantation was the procedure that was done. And presumably sometimes these don't come out very nicely and they just shred them and then they leave these in. They leave those in. Jeff, do you want me to show one more? Do you have time, or are you going to show cases? I can save mine for another time.
You can do one more. I just got one or two I'll show today.
Okay. This one is from Leif, so he alerted me to this one. So the only history that I think we had and that he had was this person had tracheostomy for tracheal narrowing. And I'm not sure exactly what diagnosis she carried when she came here or what she's had, but she's had this tracheostomy for some time for a tracheal stenosis. And then when we looked at the CT, and when Leif looked at the CT, let me bring this one up. I don't know if we have thin cuts. Well, maybe we have some. Yeah. He did notice that in looking at the, maybe I'll start off with non-thin cuts. Looking at the appearance of the trachea below the level where it terminates, you can see that the anterior portion of the trachea is narrowed and the posterior membrane portion is not narrowed, and perhaps the same phenomenon right here. So we raised the possibility of relapsing polychondritis as the actual cause of the tracheal narrowing. I don't know if the diagnosis was made before, and then subsequent clinical notes have mentioned relapsing polychondritis. So I think it is probably going to be a case of relapsing polychondritis in this person as the etiology for that. I think she has sinus disease. I don't think she has ear disease, but certainly from the point of view of imaging, this is very consistent with the pattern of tracheal narrowing from relapsing polychondritis as the etiology in this person. So I thought I'd show that. Nice demonstration of the posterior membrane sparing.
Yeah, Howard, I can't think of anything else that would look like that.
Very suggestive, isn't it?
Yeah.
Yeah.
It's a small.
Yeah.
Excellent.
So that's the way that we reported that out, that left, and I looked at it too. Yeah.
Okay.
All right.
Cool.
Okay, let's see. I'll show this one if we can get it to load. All right, so this case, and I'll pull up the images in a second, was the story was that this lady presented to her primary care physician with a big neck mass, which I thought I had. Here it is. And they had ordered a chest CT, and I called and asked, why are we getting a chest CT? Because I thought maybe we wanted to do a neck. And I was explained to me that, well, there was this neck mass, but it also went down into the chest, and there was all this bruising and stuff on the abdominal wall. So I said, okay, fair enough. And we did this CT, and you guys do see it, correct?
Yep.
There's this infiltrating soft tissue in the lower neck, supraclavicular fossa, and you'll see the same thing in the right axilla. And this patient was in her 70s. And you see some lymph nodes sort of hiding in here, but lots of stranding. And the only other thing I noticed, the lungs themselves were fine, was this intraatrial septal mass. And you could see the indentation on the left atrium. So I didn't like that just for lipoma or fat, and it looked like there was too much soft tissue. But I was trying to tie this all together. And she did get an abdominal CT. It showed a mass in the mesenteric fat. And then a neck CT just showed more of this stuff, all this necrotic. So we assumed this was some kind of metastatic, and there was an adrenal mass, some kind of metastatic carcinoma coming from somewhere with extracapsular spread. But we didn't know what it was. And she had a big hematoma on her left anterior abdominal wall, which no one could really explain. So they did a biopsy of the axilla mass, and it came back as a high grade. They called it a triple hit B-cell lymphoma. It apparently had 3 different mutations. It looks ugly, and apparently it's a bad lymphoma. So it was kind of an interesting lymphoma, but for some reason we can't quite figure out. They wanted a cardiac MR to look at this atrial septal mass. And let's see if I can find the, here's a contrast enhanced post-contrast T1, looks like it's T1 fat sat. We see all the enhancement in that area, and it extends into the upper abdomen as well. So going along the IVC here. And I wanted to see if I had the other ones. Here's another image. I don't know if this one's good. No, that's not what I wanted. I thought I had a different contrast enhanced sequence, but that does show it pretty well there. Here's a delayed enhancement. There we go. And you can see all this tissue in there, kind of narrowing the IVC, the right atrium and all that. So, and you see it around here around the IVC. So this is all presumably lymphoma too. So it's secondary cardiac involvement, but just kind of a very odd manifestation with this extranodal inflammation and just multiple sites throughout the body.
So Jeff, the interatrial septum is a place I look in every leukemia and lymphoma patient.
Okay.
That's a little. It's a little. I've seen, I don't know, at least a dozen cases now, including this and other ones that we've shown. I don't know why, but it's a place that they'll both occur.
That's good to know. Okay, and this is kind of a cool case from an imaging standpoint. And let me show the image here. So this is a patient with metastatic lung adenocarcinoma and has bad disease. You can see there's stuff all over. But what struck me about this case, and this is my new sign, this is the hairy caterpillar sign. I've seen this twice this week, is this sort of venocentric or angiocentric, I don't even know what to call it. It's not really a nodule, but these opacities in the lungs. And you see a lot of these. I mean, we see some larger discrete nodules. But I think what these are they're engorged veins from tumor involved in them. I think these are endovascular metastases, but unlike the arterial tree and bud metastases like you can see with a renal cell, which I have a case, maybe I'll try to have it for next week to show the contrast. I mean, this one has some of that. I think these are, and I should go back, the tumor's down here, it's growing up the bronchovascular bundle, and you can see there's mets, but I think these are all endovascular metastases, and then this hairy caterpillar I like is sort of a venous metastases, and you're seeing engorged side branches draining into these veins, because normally you don't see this many little side branches in any of these veins, especially that front. This is more normal. You see a few for about a couple millimeters of the side branch, but this guy up here, where did he go? You see all these little tiny side branches going all the way to the pleural surface. So I don't know, what do you guys think of that? Or my theory?
That it's vascular and maybe venous, huh? Wow, it's a good thought. I guess. Wow. I don't know. There's so.
Yeah, there's just, if I put them up a MIP, for example, let's make some MIPs. Here, we'll use the smoother algorithm here. Just see, it's all centered around these venous branches. See how you got all these little nodules marching along the vasculature. It's purely a curiosity.
Mm-hmm.
Yeah.
Doctor, but anyway, I thought that was kind of an interesting thing. And
No, it's a big button, yeah.
really quickly, this is a incidental patient. Hold on, let me show the screen here. So this was a trauma patient here. And, interesting, I was asked about this case, and there's these cysts, and there's emphysema. So I think this was just an incidental LCH in a trauma patient. Interesting, the cysts go down pretty low, but I think when you get very down to the bottom, they sort of just fade out. You might be able to find one or two, but would you guys think that and the patient was a smoker, would you query anything other than LCH?
Is it sort of an older person that could have Sjogren's syndrome, or
No,
these?
I believe it was a younger person, and had no connective tissue disease. That was the other question. I thought they were too upper lung predominant for Sjogren's, and in the setting of smoking, that was what I kind of favored, was LCH. But I don't know. I think that's over here. That was one.
Going to the outfield again, are quite a few of them subpleural, because the cysts of LCH are usually more central.
Right.
Usually.
I think that's paraseptal emphysema, though.
Oh, okay, maybe both.
Because it's only in the upper zones, really, and like this looks more like emphysema. There's some central lobular, and then you got more well-defined cysts in the middle.
Jeff, is it a boy or a girl?
Good question. It is a girl, but I don't think that makes a difference. Well, for Sjogren's it might, but I don't think for LCH it makes a difference anymore.
How about, but you have to bring up lamb if it's a female.
I didn't like them for lamb. I thought they weren't. I thought they were too upper zone predominant. I mean, you really don't see a lot of cysts down in the lower zones. You see a whole bunch on any given coronal slice.
And there are some lesions that sort of blend with emphysema too.
Right.
So I prefer Langerhans cell too.
Okay.
Yeah, I agree. They do look a little regular though.
Yeah, that was the only odd
for Langerhans. And you have a couple that are in the lingula and the right middle lobe, which, as you pointed out, is pretty unusual.
Mm-hmm.
I don't know.
It's weird. There's not many.
It is predominant, so it's not doesn't absolutely avoid the lower lungs. It just doesn't predominate down there. It's not uniform.
And it is sparing sort of the tips, which it classically does.
Yeah.
And an otherwise healthy person who crashed their car, I was going to go with LC. My favorite diagnosis was LCH with some emphysema, and the cysts were just a little bit more regular than we typically see.
Yeah.
Was it a self-driving car, or was this person in command?
I don't know. we get a history of trauma, and I have to rely on the generosity of the first nursing note when they hit the ED for any real history. Okay, well, thanks everybody. I hope to see some of you in Boston this weekend. And
yeah, are you back in time for next Thursday?
I'm coming back. I got to come back Monday night, so I'll be here.
Okay. Yeah, I'll be around. I'm not going to Boston, but safe travels to everyone that is.
Okay.
All right, bye everybody.
Bye everyone.